So the biggest takeaway from that study is that when people who don't have a history of serious mental illness take semaglutide for weight management, the drug does not seem to increase their risk of depression or suicidal thoughts or suicidal behavior as compared to placebo. And that's an important finding because there has been concern from some large studies that have used surveillance data from the general population. There's been some concern about suicidal ideation. But this study, which was a well-controlled trial, there were 4 randomized controlled trials who were pooled together. And they showed when you do careful assessments of people and you can carefully characterize the population, under those circumstances, there's really no signal of suicidal ideation or depression or suicidal behavior. And I think the difference in conclusion is based upon the difference in the types of studies that they are, the designs used. So our study was a randomized controlled trial where people are assigned to take either the drug, semaglutide, or placebo. And in doing that, when you randomly assign people, you can test to see, does this drug, first of all, cause weight loss? You can identify that. You can also see, does it seem to cause adverse events, whether it's nausea, vomiting, or suicidal ideation, depression, suicide attempts. And you have a very clear ability to see cause and effect because you're using a randomized design. The study that you're referring to, which found a signal, is based upon surveillance data, where patients and doctors are reporting to the Food and Drug Administration, the European Medicines Agency, if they have some sort of a negative event, whether it's psychiatric or otherwise. And so this big report that you're referring to looked at surveillance data. And surveillance data are critical because you can get hundreds of thousands of people, a much bigger population than you can in a small randomized controlled trial. But the limitation is that, one, you don't have a good measurement of, well, what is suicidal ideation as the patient reports it? Is it serious or is it not serious? And by that, I mean, suicidal ideation can be looked at in 3 different categories. One is sort of passive suicidal ideation, where you feel like, well, I'd kind of like to go to bed and not wake up. That might be easier, but you're not having any thoughts of ending your life or really wanting to die. And then you have serious suicidal ideation, where you have a wish to die, you have an intent to die, you really want to die, and you have a plan to kill yourself. So studies that are getting reports from general practitioners or from patients often can't discriminate between the degree of suicide. And then a larger problem is that when you're sampling reports from the general population, you don't have good information about their background experiences. So were there similar rates of mental health problems in the larger study that you're referring to? And that was the paper in JAMA Open Network. Were there differences between the groups in their prior mental illness? Were there differences in their rates of obesity, things that can influence reports of suicidal ideation? So the authors of that paper say very clearly there are 9 limitations of our study. And the second one is, they say, second, the well-known inability to infer causality does not allow us to attribute any reactions to the effect of a drug. So they sort of say, we know that we can't say that the drug caused these problems. The essence, they say, it's possible the drug could have caused it and more research is done. So more research is needed where you examine patients who do have a history of suicide, depression, who take the drug. And what I think you need is small pilot studies that are well controlled, well designed, like our study is. But our study does have a fault, which it didn't include people with active ongoing major depression, didn't have people in it who had serious suicidal ideation. So for our study, we can say, well, it's safe if you don't have mental health problems. But if you do have mental health problems and you took the drug, we don't really know how safe it is. So that question remains open. So that's what happens. And there are lots of papers out there using surveillance data that are coming to different conclusions. And it's because the populations you're studying are not well controlled and you can't be sure about the results of your analyses because you can't randomly assign people. The European Medicines Agency, I think it was back in April, said we have looked at all the data we can find, randomized trials and then post-marketing surveillance reports. And they say after looking at all the data, we do not detect a causal association between GLP-1s and suicidal thoughts or suicidal behavior. I think that you have to sort of go with that conclusion because they are an unbiased body. Psychopathology means mental illness. And so they don't have any major mental illnesses. And specifically, patients could not have had major depression in the past 2 years, so that you can't have had a experience where you've had depressed mood or loss of interest or pleasure in doing things, and you meet criteria for 4 other items on the DSM-5. So they couldn't have had major depression in the past 2 years. That excluded them. They couldn't have bipolar disorder. They couldn't have schizophrenia. They couldn't probably have severe debilitating anxiety disorders. So those people were excluded, and that's why we're limited in generalizing our results to patients with significant mental illness. My thought is the mechanism is that the drug appears to be safe as placebo from that standpoint. Our paper actually shows an interesting thing. We didn't make a lot of it, but if you look at the number of people who develop moderately severe or greater reports of depression using the Patient Health Questionnaire 9, it turns out that more patients on placebo than on semaglutide are likely to develop moderately severe or greater symptoms. So it looks like the medication, probably by helping people lose weight, is protecting them against negative mood. It's a very tiny difference, though. That's just a difference of like 1.3 percentage points. And that's why we don't think it's clinically meaningful to talk about it. But if there's any mechanism, it's probably the people losing weight are happier than the people who are not losing weight.